While we're getting back to our seats, I'm just going to go over a couple of other quick things before getting to tracking compliance. So there were a couple of other questions and other things that I think commonly get asked. One thing is about the Soclean device. I don't know, I assume all of you have seen those damn commercials about the Soclean device. It's actually not a bad device. A lot of patients assume that it takes the place of cleaning the masks. I don't know did you guys talk about it over there at all? The Soclean device is an ozone device that sanitizes and sterilizes the equipment. It is not like a dishwasher, though. So, I mean, I always tell patients, you can take your mask, dip it in mud, put it in the Soclean device. It will come out with sterilized mud on it. But you've got to, so all the oils and all that stuff are still on there. So patients still have to go through that. Also, it smells like ozone. So patients have to put it in right after they use it, and then they got to take their mask out and let that smell dissipate so that they're not inhaling that all night, because that can be irritating. I don't sell Soclean devices or anything like that. A lot of patients ask about them, and there are limitations to what those things can do. The other thing is about setup. I just wanted to say that make sure that the DME folks that you send patients to are actually taking the time to fit the mask right, to turn the machine on, and have the patient lie down. Sounds straightforward and simple. It doesn't get done. A lot of times, patients show up to the DME office. The DME person looks at their face and says, I have 25 years of experience. This mask will fit you fine. Good luck. And that's it. That was their setup. And the patients, go home, put it on, lay down. Things change when you lay down at night. Patients with congestive heart failure, they'll have redistribution of fluid, and there are a lot of things that can change with mask fit. So having that patient fitted, lying down at pressure is really important. So try to quiz your DME setup folks about whether they're doing that sort of stuff. Nasal congestion, we heard a bit about nasal congestion. Patients who have nasal congestion, sleep apnea itself causes nasal congestion. We don't know exactly why that happens, but it does. A lot of studies done in Japan showing that patients will have better compliance the wider open their nasal passages are. When I am seeing patients and I ask them about nasal congestion, and I know I'm sending them for a sleep study, I may start them on some nasal steroids in anticipation of that, just to get those nasal passages open, because I know that it's going to be easier for them to tolerate that flow when they finally get the CPAP. So it's something I'm thinking about just to begin to ease their way and get the nose open in anticipation of that. And then the last thing was a question about obesity hypoventilation syndrome. Patients, morbidly obese folks who have obesity hypoventilation. Incidentally, I run into this all the time with residents. They just assume that any obese patient with a sleep apnea has obesity hypoventilation. That's not true. One of the indicators of obesity hypoventilation will be when you look at the metabolic panel and their carbon dioxide or their bicarbonate on their metabolic panel is up. It should be 24. When that gets north of 30, that is a sign that the kidneys are compensating for something, and it could be from hypoventilation at night. If you see that, be thinking about sleep apnea, but just because your patients don't have hypoventilation syndrome doesn't mean they don't have sleep apnea. But if they do have it, those patients definitely ought to be in the sleep lab getting checked out. All right. So again, we talk a lot about the initial diagnosis, the screening and all of that, and that's awesome, and patients can get diagnosed and get their machine and then go on to never use it again. And we have spent a lot of money, we've introduced this thing, and we haven't helped the patient at all. So we want to make sure that with regard to compliance that we've done the education, make sure that the patients understand the severity of their disease. So we try to see all patients back, or at least have a phone call if they'd prefer that, to go over the results of their study in detail, let them know exactly how bad their disease is, get them psyched up for this is going to be awesome, this is going to change your life, and this is going to help you out. So get them motivated. Every patient has to demonstrate compliance. They have to have a follow-up face-to-face visit with the person that prescribed the machine. 30 to 90 days after initiation to look at compliance. How do we know whether they're compliant? We look at those downloads. So those machines can transmit the information. That's available online. So patients can authorize you as the provider or us as the provider to view that information online, and we can take a look at their compliance. Compliance is defined as usage, again, greater than 4 hours for 70% of the days. I have some patients that struggle with their CPAP, and the machine can tell them how long they've been wearing it that night. They will wake up periodically, look at that. Once it says 4 hours, they rip the mask off and say, hey, I'm done. I've met compliance. Isn't that awesome? Well, technically, yeah, maybe you're meeting compliance, but again, that's the minimum at which we begin to see clinical improvement. So if they're only meeting 4 hours, that means, probably there's another 4 hours of bad sleep apnea that they're enduring the rest of the night. And so they may be saying, well, I'm compliant, but boy, I don't feel that much better. Well, okay, you're compliant, but we're not optimally treated yet. So compliance does not mean optimal treatment. Keep that in mind. Compliance means the insurance company will say, okay, you can keep using it. And again, for CareOregon, thankfully, that isn't an issue, but for every other patient, it is a big issue. And if they aren't meeting compliance, insurance will say, and I think reasonably so, expensive machine, you're not using it, we're taking it back. And for Medicare patients in particular, if they have demonstrated non-compliance for whatever reason, Medicare then says if you have demonstrated non-compliance and now you want to be retreated 6 months later, you have to start all over again. Like, we've got to re-diagnose you and spend all the damn money again. It's crazy, but that's the fact. So we want to get that compliance and maintain it. And again, not only do we want compliance, but we want symptom resolution. So we want clinical success. Don't just accept compliance. Make sure we're troubleshooting those issues. We can arrange for the download online. So we talked a little bit about clinic champions and about how we do this. If this is something you are willing to do, first of all, God bless you. Second of all, we want to help you with that. But we got to arrange a system in your office for doing this sort of stuff if you want to see these patients back. Again, we will hopefully establish compliance initially. What I'm talking about your help in is ongoing compliance. That annual visit, or that at some point checking in with the patient, looking at their download, making sure they're still using that machine a year, 2 years later. And if they're not, why not? How can we get them back? But getting that download, making sure there's a mechanism for that is done fluidly in your office, so that when you're seeing that patient, you've got the download to review with them when they're in your office. Have them bring the equipment to the office visit too, because sometimes the problems are with the mask. You get a chance to take a look at the mask. Do it. Look at the mask. You will see some beautiful, colorful fungi. These things look like beautiful terrariums sometimes. It's really quite amazing what some people are continuing to put on their face if they're using it. So this is a look at what a compliance report looks like, and this looks pretty daunting. There's a lot of information here, but it's not that complicated. This stuff is doable, and it's pretty doggone easy once you start looking at it. I don't know what I did with my pointer. Can you check and see if it's in the pocket of my coat there or on the table? So this is a compliance report for Barney. You see at the top there the duration of this is the last 30 days, that from the 14th to the 13th of July here. So it has the date range. It has the days with device usage of 30 days. Not there? That's all right. Was it up here? Oh, does it? Sorry. Okay, great. Oh, perfect. So again, here it tells you how many days we're looking at. It tells you percentage of days with device usage is 100%. That's not the same as compliance. That's just saying they attempted to use it. What we see down here is percentage of days with usage greater than 4 hours. I wish this was highlighted or an asterisk or something, but this is where the money is right here. 100%, awesome. Every night they're using it more than 4 hours. They're averaging 8 hours and 17 minutes. And their residual AHI, remember that's the number of times per hour that they're having respiratory events, 5.7. Normal is less than 5. This is pretty doggone good. Of course, it depends on what they started with, right? So if they had mild sleep apnea and their initial AHI was 8, maybe 5.7 isn't, optimal, but it's better. If their initial AHI was 120, man, we're doing great. This is awesome. And then in this particular case, this patient is on auto settings. So we can see here that the patient, it says auto CPAP summary here. Auto CPAP mean pressure, 7.5. Device pressure less than 90% of the time was 8.5. That means that 90% of the time their pressure was at 8.5 or lower. So they're doing fine there. This is the same patient. This is a little summary graph that a lot of these things come with. So you can get a wealth of information from these downloads. You can get a summary, which is usually 1 or 2 pages where you get the bullet information. You could also go as far as to look at the waveforms of their breathing on an individual night or look at individual nights and their usage. But this is just the summary. Right here we have a graph. This is awesome because right away I can tell you this line here, this black line is the 4-hour line. And we got green bars going across, boom, compliant. I don't need to look at the details. I know just from looking at this thing, that's all I need to see. This patient is obviously compliant. Again, they were on the auto CPAP. This actually tells you what pressures they were on, 7 to 20. And remember, I said their 90% pressure was 8.5, so they're only using the pressures from 7, 8, and 9 on their auto pressures. It's bouncing up and down between those pressures. You can get all sorts of other information here. This talks about the ramp. Ramp start pressure is 5. The ramp is the only other, there's like 2 buttons on these machines. The ramp is one of them that has a little triangle on it. Patients who wake up and maybe are set at a moderate or high pressure, if they're struggling a little bit early on, they can hit that button. The pressure will drop down to 5, and over the course, in this case, of 20 minutes, it will ramp back up to whatever their optimal pressure is. So it gives them a little bit of time to fall asleep. This is what some patients feel like when they're, we heard about duct tape earlier, of what they feel like with trying to get the mask on. These are other compliance reports. This looks like, oh my God, this looks like, we're launching some sort of spaceship here with all this different stuff here. But when you look at it carefully, it's just not that complicated. This is showing the compliance in a little bit different way. Again, you can get a lot of different information on these downloads. I don't want to overwhelm you with this, but just to show you that it's nice to be able to find out, you ask the patient, so how are you using the machine? And they say, oh, I'm using it every night. And you're sitting there with the download showing you, and no, you're not. And you can ask them questions about that and where they're struggling. You've got information here. In fact, this shows you not only how many hours they're using it, but exactly when they're using it on a 24-hour cycle. So you may see, in this case, the patient's doing okay. They're struggling a little bit in here. Here you can tell that something's going on. They're putting it on, at 10 o'clock most nights, but some nights, this looks like the weekend here. They're staying up a little bit later. Sometimes you'll see that maybe they're putting it on, but every night at like 2 o'clock in the morning, it stops. What's going on? Well, I get up to go to the bathroom, and I just don't feel like putting it back on when I get back. Just a quick tip for that. A lot of times we tell patients, don't take the mask off. Disconnect the hose, wear the mask to the bathroom so that you don't have to fiddle with putting it all back on. Just pop the hose back on when you get back into bed to alleviate some of that. But we hear that a lot, that patients, and you'll see it a lot on these downloads, that patients are, getting up for some reason and then just not putting it back on, just not wanting to go through the hassle of it. Patients with poor compliance, again, significant improvement in symptoms requires more than just the 4 hours. When I'm setting patients up, I usually tell them, let's try, as you're getting used to it, the machine doesn't know whether you're awake or asleep, right? So you can wear it during the day and jumpstart that compliance. by watching it during the football game or the basketball game or whatever, you get 3-4 hours of compliance right there. You don't have to be asleep. Just getting familiar with the mask is going to make it easier. So I tell patients, let's put it on while you're watching TV during the day or while you're otherwise distracted. You can be reading or doing other stuff. You can be, visiting with friends or whatever. But distract yourself in some way. It's kind of like a new pair of shoes. You got to wear it around for a little bit, break it in, get familiar with it. You're asking these patients to undertake a tremendous change and a tremendous intervention in their life. And as we've discussed, it can be quite daunting. So the more they get familiar with it, the less likely they are to wake up and feel like, oh, what's this thing on my face? That takes time. Keep putting it back on. Keep putting it back on. Patients who take it off in the middle of the night, I tell them, sometimes we have to set an alarm for 2 o'clock in the morning to do a mask check. Sometimes I tell them, take a wisp of hair and put it in the Velcro or whatever so that when you take it off, you're pulling your hair and you wake up and put it back on. You got to be creative about thinking about how we're going to help with this compliance. But the key thing is put it back on. If you can get them over that hump of the first couple of weeks, you can get success. But if they're struggling and only wearing it a couple of nights, a couple of hours, a couple of nights a week, they're going to struggle. So upfront education and encouragement. Consider consultation with a sleep tech for desensitization. I alluded to this earlier, but if you have a patient that you know is going to struggle, they complain about claustrophobia, maybe that's a patient that would do well to come in during the day. Just lay down in the sleep lab, like I said earlier, put the mask on, watch some TV, let the tech kind of troubleshoot things. Let's get them some confidence and familiarity to get them jump started. Or consider the alternative masks. We can tease out from them, what is it about this that's the stumbling block? And just asking that question, so what's the biggest stumbling block for you? Okay, well let's make sure your humidification as well is at the right level because you have a dry mouth. Well, let's make sure you're cleaning the mask if leak is the problem. Let's make sure this is the right mask. And really sort of teasing those things out one at a time. If you're sending a patient for a consult with us and you ask them, has anybody ever assessed you for sleep apnea? Oh yeah, I had a sleep study 3 years ago at wherever Kaiser or wherever. If you can get a copy of that or acquire that and send that along with them, that is really helpful. If they currently have a machine but they're not using it, please tell them, okay, you're going to go for this consult. Take your machine with you. Bring the mask with you so that we've got all that stuff when we're seeing them for the first time. Appropriate indications for a sleep study. So excessive daytime sleepiness, we've talked about this. The Epworth greater than 10, the stop bang greater than or equal to 3. We usually say insomnia is not an indication for a sleep study. So if a patient's got insomnia, we often want to talk to them about what are the reasons for the insomnia. Now, it turns out that insomnia and sleep apnea are comorbid a lot of the time, and particularly when it comes to a sleep specialist, if you take a look at patients who come to my office with insomnia, up to 70% of those folks will have obstructive sleep apnea as the primary cause of their insomnia. Now, out in the general population, it's much less than that, and insomnia is caused by a lot of different things, and in fact, I can do I just gave grand rounds on insomnia about a month ago at Providence. I can come back and do a whole thing on that. But insomnia is a different beast. But patients, if they've got insomnia, think about that whole different track before sending them for a sleep study, because you can send them for an expensive sleep study. If they've got insomnia and they don't sleep, we're going to have difficulty making a diagnosis. So a lot of times, and if you're not sure what to do, we can see those patients first. A lot of times we won't get the sleep study up front. We'll deal with the insomnia part first as much as we can. And then once we've got them sleeping a little bit better, tease out whether we think sleep apnea still needs to be assessed. Bariatric surgery candidates, and then narcotics. This is a big one. A lot of patients on chronic narcotics. A lot of concern in that population for central sleep apnea. This is a population where we will be more inclined to get a split night in-lab study on those patients on chronic narcotics. because central sleep apnea is not well assessed by a home sleep test. Sleep studies not indicated. Insomnia alone, again, for the reasons that we discussed. Restless legs alone. It doesn't mean that, so much of the time we get these referrals, sleep problem, get a sleep study. I don't know what, I asked the patient if they slept well, they said no, go get a sleep study. Yes, we will be able to hopefully tease out what the problem is, but it may not be an indication to send them directly to the sleep lab. At the end here, I say, when in doubt, consider sleep consult. Intolerant of CPAP, we get a lot of these referrals to the sleep lab as well, which is, patients having problem with their mask, get another sleep study. No. Patient having problems with their mask, that's a time to send them maybe for the sleep technician visit, send them to the DME to get the mask reassessed, make sure it's the right fit. Does not mean we need to spend a couple $1,000s in the sleep lab to get another titration. We need to suss out, what their problems are. But that happens a lot. Or, their CPAP mask is broken or their machine's broken. Go get another sleep study. No. Let's back up a second and see if there's other ways we can work those problems. So refer back to DME. X number of years since their last sleep study. The patient has sleep apnea and they're coming back saying, yeah, I've been on a machine for 5 years, but I'm more tired now. They don't necessarily need another sleep study. Maybe they just need to be put on some auto-adjusting CPAP first. And that's often what we'll do, is just switch the machine over to auto, see whether or not they do better with different pressures. But the first thing in that instance, or in a lot of these instances, look at the download. If they're doing great, maybe the problem lies elsewhere. Maybe it's not a problem with the machine. Maybe it's a problem with their caffeine or their alcohol or their narcotics or, some other issue that's causing them to be sleepy during the day. But again, when in doubt, we are happy to help you with those guys. Consult recommended. So home sleep apnea test, why do we say that? A lot of times the American Academy of Sleep Medicine actually recommends that all patients who are going to be sent for a home sleep test get a full sleep consult before they get their home sleep test. That's great in an ideal world. With the numbers we're talking about, it's just not going to be possible ultimately. We are trying to do this now, and it's overwhelming. And that's why patients are having to wait long periods of time for sleep studies. We are working now on developing a pathway within a CareOregon pilot program. We're going to hopefully get one set up. And if you want your clinic to be part of that, and you are motivated to sort of become one of those sleep champions and want to work this problem with us, let's do it. And figure out the best route and the easiest way to get patients through this process. Parasomnias. So if your patient is having other problems, sleepwalking, sleep eating, night terrors, possible seizure, that's a reason for a consult. That is not just go to the sleep lab. Persistent insomnia, for all the reasons we've already talked about. Narcolepsy, that's a bigger problem. We need to see those patients first because they probably need to undergo additional testing, not just a sleep study, but oftentimes something called a multiple sleep latency test after their sleep study. Suffice it to say, patients with more complicated sleep issues, let's do the consult. Circadian rhythm disorders. A lot of times these patients manifest or present as possible insomnia. This is the person who says, boy, I just can't fall asleep until 2, 3, 4 o'clock in the morning. But when you ask them a little bit more about that, it turns out that they sleep from 2 o'clock in the morning till 10 o'clock in the morning and they wake up feeling fine. That's actually a delayed sleep phase. That's not insomnia. In other words, they're getting adequate hours of sleep. They're awakening feeling well rested. They're just getting it at a different time than most people. They may think they have insomnia because they've got to get up at 7 o'clock in the morning to get to work, but they can't fall asleep until 2 o'clock in the morning. They're not getting enough sleep, but it's actually a circadian rhythm disorder, not insomnia. Complex sleep apnea, these are folks who, when you put them on CPAP, they end up having central apneas. This is a lot of times on those compliance downloads, you'll see these folks having lots and lots of events. It looks like their sleep apnea is poorly treated. The obstructive component might be treated, but now they're having central apneas. So if you're getting a download and it's showing actually the patient's doing great, they're using the machine, but their AHI is still really elevated, that might be a reason for them to come back and see us to suss out, do they now have central apneas and need a different line of therapy for that? Not sure what it is or what to do, or I don't feel comfortable dealing with it. That's okay. Let's work on that patient, and then we'll send them back to you with sort of what we did. Maybe you can learn from that. And a lot of this is just demystifying it and beginning to get comfortable with it. It all sounds kind of like, there's all these devices and downloads, and oh my God, it's overwhelming. It's not rocket science. We can. It's actually much easier when you begin to figure it out. I include in every talk this one, these slides. I think I have some more compliance stuff if you guys are interested and willing to look at a little bit more about that. But I do like including these slides. You're getting sleepy, very sleepy. At the count of 3, you'll not wake up. And this is about the risks of drowsy driving. So while you're assessing these patients, it's important to ask about driving for your safety, for my safety, for the safety of the community. Drowsy driving and sleep apnea is a huge cause of accidents, and not even just fully falling asleep at the wheel, but actually micro sleeps. So these folks, people with sleep issues, are chronically sleep deprived. They will be having micro sleeps, and maybe you've experienced these where you don't really remember getting through that last stoplight, and you're like, man, how did I don't even remember, was the light green? I don't even. The micro sleeps, it doesn't take long, depending on what speed you're traveling and where you're driving, to cross that center line. A second at 60 miles an hour can be the difference between life and death on the highway. This is an example of a tragic incident where the school bus driver fell asleep. So drowsy driving, 27% of patients report having driven drowsy at least a few times per month. 12% say a few days per week. 4%, that's a lot of patients, a lot of cars that you've driven by every day. So 20% of all auto accidents in the US are due to driver fatigue, 100,000 motor vehicle accidents a year. 36% admit to falling asleep behind the wheel of a moving vehicle. So that's really scary. So please, if your patients are talking about this, and a lot of times it might be a month or two until they get in to see us, you got to talk to them about drowsy driving. And I usually put it this way. Look, you've now complained of a sleep problem. You've told me that you fell asleep behind the wheel. This is like driving drunk. This is going to be documented now, and we're sending you to a sleep specialist. If you fall asleep behind the wheel and God forbid something happens, that is now manslaughter, basically. If they now subpoena your records and find out you knew you were sleepy, you got behind the wheel and you killed somebody or hurt somebody, that's a big deal. And that's not, I'm not trying to threaten them with, boy, you shouldn't have told me, but just to tell them this is a big deal. This is like drunk driving, and this is serious. And, it's bad enough. We want to treat your sleep apnea, but boy, we really don't want to have, somebody else's injury on your mind and on your conscience for the rest of your life. So please take drowsy driving seriously, and make sure that you're talking to those patients about, if they're really bad, let's stop driving. Let's limit the driving to short distances. What's a distance you feel comfortable that you don't fall asleep with? And make sure that you document those conversations. So drowsy driving is red alert. Pull over immediately for all of you as well. Do not risk it. If your eyelids are getting heavy, you got to stop, because the next time may be too long. Do we have any time left?
we're going to have some more time for a longer Q&A at the end, but we want to be sure to make time for our next presenter here for Mariah. Dr. Bowerfind, everybody.